I read the questions.
Okay, go for it, if you want.
Okay, how long have you been at the RCH Melbourne? Well, I have been almost 14 years now in Melbourne. How long have you been performing the Fontan operation? I have graduated as a surgeon in '96, but I've been doing pediatric cardiac surgery on my own since '98, and I started doing Fontan at that time. How many pediatric heart surgery do you personally perform each year? Well, in the Royal Children's Hospital, we treat about 650 patients per year. We do 530 bypass cases a year, and for many years we were 3 surgeons. I would say that I'm probably close to 200 patients, 200 to 300 operations per year. Of those surgery, how many Fontan procedures each year? We were doing between 50 and 60 Fontan procedure per year. We had a top at 80 or close to 80 a few years ago. And I think that we were doing around 45 a few years ago in Melbourne. It probably varies between 35 and 45, and I was up to 15 Fontan procedure per year, I think. Do you perform the lateral tunnel Fontan on the external conduit? And what are the benefits and risks of each? So the lateral tunnel was the older version of the Fontan procedure, and the extracardiac is a slightly more recent version. The extracardiac conduit was started in Australia by my colleague Christian Brizard in '96. And progressively from '96 to 2006, everybody in Australia switched to the extracardiac Fontan. So everybody in Australia, since that time, has an extracardiac Fontan, and that's the only operation I do. The extracardiac, there's a little bit of evidence that it is superior than to the lateral tunnel in terms of risk of arrhythmia. So if you have an extracardiac conduit, you have less risk to have fast heart rate, at least if you live in Australia and New Zealand, and you have a smaller risk also to have less slow heart rate, which may be a problem too. And it's a serious problem if you have a Fontan, because that leads to more problem and sometimes failure of the circulation within years, not immediately. But one should realize that the difference between the lateral tunnel and the extracardiac conduit are not huge. They're not very big. So there are differences, but they're not enormous. They're still small. And some people have excellent results with lateral tunnel. The trick with the extracardiac conduit, I think, is that it looks very simple in its concept, because you just connect a pipe to another pipe. But actually, I think it can lead to more distortion than the lateral tunnel, distortion of the lung arteries. So some people have shown that in the US, for example, the people have more problem early after the Fontan if they have an extracardiac conduit than the lateral tunnel. I would say that the debate is still open. The differences are small, and like everything else in cardiac surgery, you should stick to what you do best. If you're good with lateral tunnel, you have good results, you check your results, it's fine. If you're good with extracardiac conduit, keep going. At what age would this surgery be performed? Well, I cannot give a clear mark, but I think that there is good evidence in the literature now that there is an ideal age of the Fontan. At least it's being clear that you should not delay the Fontan after 7-8 years old. If you do the Fontan later, it has been shown that you have more complications. You have more early complications, more risk of death, of serious complications like failing Fontan, protein losing enteropathy, and you have more late risk as well. There's evidence that your exercise capacity goes down more quickly if your Fontan is done late. So you should do it early. Now, whether you should do it at 3-4 years of age, 2 years of age, the debate is still out there. There are teams, Japanese guys, who like to do the Fontan at 2 years of age. We think it's a bit early to put the large side conduit that we like to put in the extracardiac conduit, but it's open. The one thing that is certain is you should not wait to have the Fontan. You should do it sometimes in early life. How long does the Fontan surgery take? I've done Fontan which were very quick, very easy, no scar tissue, and in about 2.5 hours I was out of theatre. And sometimes I had cases where it took me 6, 7, 8 hours. So it all depends on how many surgeries were done before and how much scar tissue were in. Peculiar issue is the normal surgery as we do it in the children's hospital, because we have a route that is working very well, but the dissection of it is quite tricky at times. It takes adults easily an hour to the operation if you had a normal rather than another surgery beforehand. What risks are associated with this surgery? The risk of mortality in Australia and New Zealand is about 1% the last time we looked. I usually quote a risk of death of 1 to 2%. The risk of early failure, PLE, in particular, protein-losing enteropathy, losing proteins to your gut, is something that may happen. The main issue that is more benign is prolonged pleural effusion, having chest drain that leaking a lot. There seems to be evidence now that if your chest drains are leaking for a long time at the time of the Fontan, that is a sign that your Fontan may, and it's not like it's going to be for everybody, but sometimes may not function as well on the long run. That may be a marker that things may be a little bit more difficult, that your circulation is a bit more difficult. What is the longest lasting Fontan to date in years? Well, in Australia and New Zealand, we get people who had a Fontan 35 years ago and are still well. There are areas in the world, I think in the Mayo Clinic and in France with the first Fontan, who have had for a longer time than that. I think that some of the first patients of Dr. Francis Fontan are still alive, so that would be close to 40, 45 years from now. What is the average length of stay in your hospital after Fontan? I would say that it's between 2 and 3 weeks in average. Fontan to transplant. Ahead of the last surgery, the Fontan, we were advised that this surgery would help to give our daughter more time, but ultimately she would require a heart-lung transplant, lungs due to the additional strain pressure they endured because of the Fontan. Is this true? Well, there are no heart-lung transplantation that are done in Fontan, to my knowledge, because even though the circulation may put a bit of strain on the lungs, it's not to the point that you cannot do a heart transplantation alone, rather than a heart-lung transplantation. Now the idea of, if things are not working well, you will need heart transplantation is again a simplistic message that has been given to a lot of families. The reality is that has not become true. 1,500, more than 1,500 Fontan done in Australia and New Zealand. We had 34 heart transplantations. So 34, it's not even 3% of those people ending up with a heart transplantation. So it's a rarity rather than a common occurrence. The thing is, likely we should have done more heart transplantation than these 34 patients. There's a few patients, I believe, which we should have offered heart transplantation. That would have been a good option, but the people back off because they're scared of the amount of complication. They're not easy patients. They've been operated 5, 6, 7 times. Sometimes the liver is failing, the kidneys are not so good. And people are scared. People who are not used to this kind of surgery, when these patients are addressed to adult heart transplant services who are not used to deal with congenital heart disease, the people get scared, and so the surgery is not offered. It's the case in Australia. It was the case in Australia and New Zealand. It has been the case worldwide. In the UK and the US, we've seen some phenomena. So, yes, you may need heart transplantation at the end, but you have much more chances that you will not need heart transplantation. The issue is as well is that if everybody needs a heart transplantation, that will be put an enormous problem to the society because we do not have this heart. We're doing, as I said, about 60 Fontan per year in Australia. We're doing 80 heart transplantation in Australia and New Zealand. 80. So right now we're doing a heart transplantation to between 0 and 2 patients a year in Australia and New Zealand. We cannot bring that number to 40 or 60. That's going to be impossible. So we're going to have to find other solutions. So I've answered the questions, do all Fontan patients require heart and lung transplant eventually? The third question was, if they reach 50 without it, a transplant, are they sent to the bottom of the list because there is some 25-year-old that also needs it? The way that, it's not a question, but the way that the transplantation list works today in Australia and New Zealand is that the people are listed following quite strict criteria. They really need the heart transplantation to be on the list. Once you are on the list, if you are trouble and you cannot wait, then you can be bumped up at the top of the list. So if you're in a more precarious state, you may get a heart transplantation more quickly if you cannot be supported by a machine, which is a very frequent occurrence now in the adults. The adults waiting for heart transplantation. Now the Fontan situation is a bit interesting because they're a bit of at a disadvantage because they used to have reduced flow into their body and they're quite used to a precarious state. So they don't complain a lot and they don't look that sick. So when they compare to adults who had a myocardial infarction, a heart attack, or a weak heart, well, they seem to be doing better because their degradation is so slow that they adapted to their situation. But also, so that the people tend to wait to give heart transplantation to these people. But also, the kidneys, the liver is deteriorating. So when they look really sick, then they're much more sick than the other patients. And so the big question is, at what stage should we offer heart transplantation? And that's an unresolved question yet. And there's a lot of competition for this organ. So there's going to be a lot of reluctance to offer organs to Fontan patients who may well benefit at an early stage because they will be competing with adults which seemingly are much more sick at the time. Medication anticoagulation. What type of medications are required after Fontan surgery and how long will the child be on them? Well, clearly you need something to thin the blood, anticoagulation. You're better with anticoagulation than without anticoagulation. There seem to be, in the mind of doctors, difficulty to decide whether warfarin or aspirin are equivalent. Most of the study would indicate that aspirin is actually enough, but that's not convincing everybody yet, and there may be some group of patients that may benefit from warfarin compared to aspirin. It's still a work in progress, and I have biased view on the topic. Undisclosed, disclosed, I'm not sure. Then there are a lot of cocktail of medications. The doctors have used a lot of drugs that are used for heart failure, like ACE inhibitor, captopril, lisinopril, the most frequent names. what happens is that if you have heart failure, your heart does not pump enough, so if you dilate your arteries, there's more blood flowing to the body. If you have a Fontan circulation, there's not enough blood going to the heart, so the heart does not pump enough. And so the people tend to give drugs to dilate the arteries. Because the arteries in the limbs are a bit closer, tighter in a Fontan circulation. But the arteries in the body may be tighter because that's what you need if you have a Fontan circulation. And if you dilate these arteries, it has been shown that actually your exercise capacity decreases. There's no proof that these drugs have any benefits on the long term. Still, about 2/3 of the patients are on these drugs. And so the debate is out there, and we're not the only institution in Australia. It's the same in some centers in the US. So the debate is out there whether or not these medications are useful, and we try to do some studies. We have a current project where we want to actually seize this medication in some patients to see if it makes any change to the situation. What side effects can this medication cause? Well, the main medications that we're using are anticoagulants, so you can have bleeding, bruising easily. Aspirin, a bit less than with warfarin. Warfarin can also be responsible for having less dense bone, and so you can be prone to fracture. The antihypertensive medications have little side effects. I'm not the most specialist doctor for medications, but they can have coughing with ACE inhibitor, so it's not always well tolerated. What evidence is there that anticoagulation is required in a Fontan circulation? So that's very strong. If you have no anticoagulation, you're more at risk of adverse events. You can have more strokes, you can have more clotting into your circuit, you can have more complication, more risk of death. The literature is very clear on that. Given the new anticoagulating in the adult medical world, will these be available to pediatric patients? Well, there's currently 3 trials on what we call a NOAC, novel oral anticoagulants. And we're likely to participate to some in Australia. This drug looks a bit magical because they kind of as potent as warfarin without the side effects of having to check the level of drugs that you're taking, but that need to be tested. Some of these drugs were tested for people with valve, and people had great hope that that would be very efficient, and it turned out actually not to be efficient. So it needed really to be tested to prove its efficiency. So what do you prefer, warfarin or aspirin? So I'll just, it's a direct question, I'll just whisper it, okay? Okay, that's all. I haven't said it publicly. Post-Fontan, high pressure in the pulmonary arteries. What medications help lower pressures, and can you take them long-term, or is there a time when you just have to face life with the pressures high? That's a very interesting question, and that's something where a lot of work will be done in the next 2-3 years. When you have a Fontan circulation, the flow is passive and it's not pulsatile. When you have pulsatility into the lung arteries with the heart, every heartbeat, it stretches the lung arteries, and you have a secretion of nitric oxide, which is a product that dilates the arteries. And you lose that when you have a Fontan circulation. So, when you have a Fontan circulation, your lung arteries are somewhat, not very severely so, but somewhat, as is the lung arteries are a bit tighter than they could be. And if you give drugs, nitric oxide, Fontan, sildenafil, this type of drugs, the lung arteries do dilate. this drug can be taken for a lifetime. And there's a lot of interest from pharmaceutical industries, and there's likely, again, probably 3 trials that will be ongoing, checking the interest of this medication in the Fontan circulation. This could be of interest and change the life of the Fontan. They may improve the life of the Fontan. They do increase the exercise capacity within 6 months to a year, without much doubt, I think. The big question is that, would there be an interest to take them lifelong? There's a big interest to take them for a lifetime, mainly for the industry, because the common feature of these drugs is they're very, very expensive. And there are diseases like pulmonary hypertension where patients are taking them every day for their lifetime. And that may be the case for the Fontan population. But we'll have to prove that it's efficient. We know whether it's efficient in a matter of 6 months to a year soon. A big question is that efficient in a matter of 5 to 10 years? Do you have a better life? Do you have better chance to live longer if you take this medication for a long-term life? To answer these questions, we likely need large international registries where we will follow some patients who are taking these drugs for 5 to 10 years. That's the only way we're going to find out, and we're working on that. Is there a time when you have just a face life with the pressure highs? You and I, everybody, will have an increase in the pulmonary pressure. With age, all your arteries get stiff, and it's no different with your lung arteries. My lung arteries are getting stiffer than when I was 20, and it's going to get stiffer and stiffer. And the big unknown now is that when you reach 50, 60, 70 years old, this natural increased stiffness that you're getting into your lung arteries, how will it affect the Fontan circulation? It's a big unknown, we'll have to watch it. With all the evidence of heart surgery, mental health, yes, it's close to my heart. With all the evidence of heart surgery patients suffering from PTSD and anxiety, is there going to be mental health support going hand in hand with medical treatment in the future? I hope yes. That's a short answer. So the evidence right now is that there's a good manuscript that has just been out from a team of Boston saying that there's up to 2/3 of the adolescent patients who have a single ventricle who at the time of the adolescence have some form of psychiatric disorder. Don't get excited. It may be very broad and wide, and it may not be anything of significance or seriousness that you would consider. And it's coming from the team of Boston who have referral from absolutely worst case throughout the country in the US. So they may have a selected population that is sicker than what you will imagine. The numbers in Australia and New Zealand, the preliminary number is that 27% of the people have some degree of anxiety or depression that would need attention, psychological support, which I would believe in the majority of the case they're not getting. So seriously, there's something to be done. We can do much better. And as the question mentioned, I think really by discussing with families that the time at which we should do something is at the time of the first diagnosis. The first contact with the hospital medium, the first contact with the disease is the most important one. And the people, you can discuss with people, they seem to suffer sequelae 10, 15, 20 years later from their first experience with the medical treatment of their child. And so that's the time where something should be done. I think I can feel that in the hospital here and worldwide, there's a willingness to tackle that problem. And it's stupid not to do it, because it changed enormously the life of the families, it changed the patient satisfaction, the consumer experience, and it costs nothing. I mean, it doesn't cost nothing, but the care of a patient who has a Fontan costs more than $300,000 until they get to the age of 18. Adding up psychological care would add $1,000, $2,000 would already be enormously efficient for each patient. That's nothing compared to all what we invest in these people, and the benefits would be enormous. We're doing also a work now in the adolescent patients. We want to support the people psychologically because we believe that that's a time where we can screen them easily because we are building up a better transition process, and we could be quite efficient at that time. That's the project that we have now. Do you believe early intervention would be beneficial to patients and families in terms of mental health? I think I've just answered that question. There's a work that's being done in the MCRI that is beautiful, where there is a study with families participating to webcam conversation with a psychologist. Can you imagine? So they're having up to 8 families with one psychologist, and that seems to have benefits in terms of well-being for these families. I mean, how much does it cost to have one psychologist for 8 families at the same time? Not much, I think. That seems like a very, very good idea. What time of follow-up care is recommended for people with a Fontan circulation? That's the $1 million question. We don't know yet. I can tell you that there's an international group that is working on the questions to make preliminary recommendation. I can tell you what we have agreed for in Australia and New Zealand so far, and we're still working together to have a recommendation. We agree that patients with a Fontan circulation should be seen once per year or per 2 years at least by a cardiologist. We agree that examination at this stage should still include ECG, echocardiography, and likely some blood tests to test the liver and the renal function. Which blood test, we do not completely agree yet. We agree that at the time of the transition between 12 and 14 years of age, we should proceed with an MRI, with an exercise study, and for the time being, and we may decide not to do it in the future, to a Holter monitoring, to look at the heart rate for a period of 24 hours, 48 hours, a bit more. In the adult world, most of the people nowadays will do on regular interval exercise study to monitor the quality of the circulation, how it's working. They will do, most of them, not all, Holter monitoring, and they will do on regular interval MRI, more or less every 5 years. There's no agreement yet, but that seems to be the trend in most of the adult centers, not all of them. I personally believe that at some stage you should check what guys like me, surgeons, are doing. You're trusting your life in the quality of the Fontan circuits. I think it's super important. Personally, we should look at it, have some good imaging by MRI or cath within a year of the completion of the Fontan. But that's a personal opinion, and we do not have that agreement in Australia and New Zealand. With the growing evidence of liver issues, fibrosis in Fontan patients, what is the treatment for this? Can you still have a transplant? Do you transplant both the heart and the liver? We do not yet have a treatment for liver cirrhosis, but it's likely it's driven by high pressure in the veins. So if you want to tackle this issue, we have to tackle that. And I believe that if you have a heart transplantation, your problems with your liver will improve. My thought is that in the distant future, if you have machines, maybe to help the circulation of the Fontan, maybe that will be an indication. Using a machine, at least intermittently, just to help the liver and relieve the fibrosis of the liver. There's experimental work that has been done with some friends and colleagues from Philadelphia, looking at the interest of spironolactone in these drugs. And there's some drugs that are specifically targeting fibrosis in the liver and apparently are efficient in other circumstances. Whether they're efficient in the Fontan circulation is unknown, but I think we will have some trial of that in the future. Can we still have a transplant? Yes. And I believe that there are more fibrosis than liver dysfunction. So compared to people who have liver fibrosis because they drink too much or because they have hepatitis, viral infection, their liver function better for the same amount of scar tissue or fibrosis that you have in the liver. So they can have more heart transplantation than some team or people believe, I think. Do you transplant both the heart and the liver? Only a very few teams have done that. And one of the only few teams who has done heart and liver transplant is backing off from that strategy. So I have, discussing back with colleagues, I have been saying that they've tried that, and I don't have the details of why they're backing off, but they don't think that's the ideal thing to do. As Michael mentioned, as time goes on for Fontan patients, there appears a growing number of liver and kidney issues. In your opinion, is there enough statistics on these to warrant a mandatory or at least a strict process of regular ongoing screening of Fontan patients? And the bracket, some patients are not told of this issue, and I recently witnessed for one family it was too late, and the mother was shocked that kidney liver issues were never mentioned. In our medical community, we have starting to talk about liver issues in the last 5 years, in the kidney issues in the last 5 years, but very little. So there seems to be growing information, but very little. Liver issues, the people agree now that we have to follow that up. So if you have a Fontan circulation, your liver enzyme, the easy things to check in the blood should be checked. Something should be done to investigate and look at the liver. The important thing is that you can have scar tissue, and if you have scar tissue, that's a field for generating liver cancer. Super, super rare. The people are talking and like to talk about it. If you read in the literature, you can read that. It's extremely rare, and it's not getting into a problem right now yet. It may become that in 10, 20 years, but that is not the case now. But still, you should check it, because that may influence your decision. If your Fontan is failing, you may want to consider heart transplantation before your liver is too damaged. Kidneys, the people argue, yes, but kidneys, we see that there's a problem, but it's not a big problem. True. It doesn't need to be a big problem. They don't seem to fail because of their kidneys, and we don't have solutions for that. Does that mean that we should not follow the kidney issues? Well, I don't think so. If we end up finding out that some patients will hit the wall because of their kidney dysfunction, the people will say, you've known that for 20 years, why haven't you done anything? Why have you studied it? If we suspect that it may become a problem and something may be done to it, then we should study it. So I think that it's so easy to find out whether you have any kidney impact. I think you should test it. At the end of the day, the more information you have on the Fontan circulation, the more information you know on how your Fontan circulation is working. The more information you have from the whole piece, the more you have a correct overall picture, rather than looking just at one thing. Most of the time you go to your cardiologist, you look at your echocardiography and your ECG, and you talk a little bit. And if your cardiologist is, a good one, you check is your saturation. It's not always the case. This ECG and this echocardiography do not tell you much about your circulation. It's likely that your liver function, your kidney function, whether you have a decreased lymphocyte count, white cell count, is a better indicator of how your Fontan circulation is working. So I think you should check. And then if there is any studies that is done to improve this liver dysfunction, this kidney dysfunction, then you can participate in it. There are some drugs that are universally good for kidney dysfunction. And it's ACE inhibitor, of which that we have talked about already. So the drugs They dilate your arteries. They target it for the kidneys, for the kidney to work better. And they may work in the Fontan circulation. They should be tried. And this issue should be discussed by the cardiologist, I think, with the patients. Many people with the Fontan circulation suffer from migraine and leg cramps. What is the thought of as to why some people have this side effect? What can be done for people experiencing this effect? It would make sense that you have migraine if you live with high venous pressure. You just have to hang by your foot, head down, to know that after a few minutes your head is starting to burst slowly. So if you have 4 or 5 times the normal pressure in your veins, why would you not have migraines? Is that a big problem? We don't know. We are currently completing a study, so in about 6 months, I should have the answer to that. Leg cramps, again, when we look at the survey, that did not seem to be a large concern. Some people have described it, and it could fit with the fact that your arteries in your limbs, as I mentioned, are a little bit tighter. What to do? I don't know about it yet. Do you think there is a need for standard guidelines of care follow-up to be established to monitor for potential change in people with Fontan circulation? How often do they have, should they have catheter, MRI, bone density, liver, kidney testing, echo, ECG? Undoubtedly, we need recommendation. We will build up international recommendation, or at least orientation of this, what should be done soon. And we will do that work in Australia and New Zealand in about 1 to 2 years' time. And it's not going to be perfect, but it's going to be a first work. That work is being done now. It is well understood that many people with Fontan circulation that have a poor quality of life due to their health will benefit from ongoing allied health services involvement, although most families experience that after their child has had surgery, that these services are no longer available to them. Are there plans to incorporate this into standard of care for these people, or is it dependent to the center hospital you attend? For the time being, it's very dependent on the center and the hospital you attend. But there are work being done in that field. Heart Kids is working on that, and I think I count on them to help us. If to say that the CEO of Heart Kids was saying is that he was working for pulmonary disease and cystic fibrosis before, and the good example is a family who had a patient who had a kid who had cystic fibrosis, and another kid who had a Fontan circulation. The kid with cystic fibrosis had all the allied health costs of care covered by NBS scheme or other scheme in the country, and the kid who had a heart problem had nothing. That's not normal, and that should be changed. And I think that in the best position to have that political change, because it's a political issue. PLE and plastic bronchitis. There are several experimental procedures, surgeries for PLE in Fontan patients. Is there a specific procedure, medication, surgery that has been more successful than the others? I understand patient symptoms vary, and this may be a difficult question to give a specific answer. PLE is interesting. If you look at Australia, we have 5% of our patients develop protein-losing encephalopathy, losing protein through the gut. If you look at most of the centers in the US, they have 10% then. And if you look at China, they have 20%. So why is that? Well, the surgery we're doing, the indications we have may be different. They have more hypoplastic left heart in the US, and that may be the reason. And then it depends how well you look after it. I mean, if you take stool specimen of every patient, clearly you're going to find more protein-losing encephalopathy. Do we know that all the patients in Australia and New Zealand have the albumin check, which is the marker of the protein content in the blood? Well, I'm not sure we know exactly how many patients have their albumin tested. Medications have changed. Clearly, the outlook when you have PLE. And the patients with PLE nowadays are doing much better than 15 years ago. Oral butenoside has been a major change. So you can have steroids that are enteric coated, so they dissolve only in a small bowel. That seems to be working really well. And yes, you will have a problem, but the problems, with the failing circulations are delayed. Now, there are some procedures that are offered. There's 2 lines of procedures, 3 lines of procedures that are done for PLE. There's some surgeries that are done. My colleague, Christian Brizard, had designed an operation where he isolated the blood return from the liver and get it directly into the heart. So you're living a bit more blue, but the pressure in the liver is less, and so the strain on the liver is less, and the liver is the biggest driver of having lymph into the lymph circulation. So more lymph is created from lymph circulation. And that's how you get pleural effusions after the Fontan, and that's how you can get PLE as well. And that's how you get classic bronchitis. So you decrease the production of lymph by decreasing the pressure strain on the liver, and you decrease the PLE. It's a very experimental procedure, and it may very well work. We have to test it. And we've decided to test it for PLE in the children's hospital. There are people in the US who are doing another strategies. They're diverting the vein that drains the blood from the left side of the left arm and the left side of the head directly to the heart, because the thoracic duct, the channels that drains the lymph from the gut, is draining just back to the heart and into this vein. So if you drain that, you decrease the pressure in the vein, you decrease the pressure in the thoracic duct. I seem to be efficient in a few people, and that's a work under investigation. There's one team that has been working a lot in the frontal circulation and in the lymphatic circulation. In particular, is the team of Philadelphia, and they have guys who go with needles through the liver. They find the lymphatic circulation and the connection between the lymph channel draining from the liver into the gut, and they block it. And that seems to be working in some patients. How long does that last? Is that just plugging a little hole that will reopen later? We don't know. All of that is under investigation, but clearly the picture behind PLE has changed in the last decade. And we're getting closer to an answer as to why PLE emerged in some Fontan patients and not in all others. Is there something specific or common denominator that occurs during the patient's initial surgery that may cause PLE to appear later in life? The veil seems to be lifted a little bit on that matter. There's a few things. If you have a higher pressure in your Fontan circuit, you have high pressure in the vein draining the liver, and likely that will generate more lymph production, and you're more at risk of having PLE and other Fontan complications. Today, we have yet not found a correlation between higher pressure in the vein in your Fontan circuit and the risk of having PLE. My belief is that it's because we're not good at measuring venous pressure. My belief is, we don't catheter measurements of this venous pressure. We put the patient asleep in a completely different situation that is usually is not exercising, is lying flat, fasted, and then we measure the pressure and we think that this pressure means something. I don't think this pressure is very meaningful. It would be better to measure the pressure, venous pressure during the whole day when they do exercise or in real life situation, which we're not doing. Then the interesting question is, the lymphatic circulation is clearly what is been driving the Fontan circulation and its complication, in particular PLE. And my mentor, Mike Lateral, who invented the lateral tunnel, was saying that to me in 98, 99, close to 20 years ago, and I thought he was talking bollocks, but he may have been absolutely right at the time. The team from Philadelphia now has got very good MRI imaging of the lymphatic circulation. And something that is not in literature yet, but they've started to explain that they're testing every patient before the Fontan, and they can score the capacity of the Fontan circulation. into 4 grades. So you can have a good frontal, a good lymphatic circulation, everything flows fine. It's a bit slower. These 2 groups are fine. There's a group where it's a bit more problematic and it doesn't flow as well. These people struggle after Fontan, they do all right, but that's okay. And then you have a 4th group where they have really not good lymphatic circulation and it's absolutely dramatic. And in these patients, we should probably try this experimental surgery that are different than the Fontan circulation. So let's move into these fields. Are we getting closer to an answer as to why plastic bronchitis occurs in some Fontan patients and not others? I think it's exactly linked to the PLE, protein-losing enteropathy. And just in some patients, it finds its way through the gut, in some patients, into the bronchus. Is there something specific or common denominator? I think undoubtedly. So higher venous pressure, even though we cannot demonstrate it, higher production of lymph by the liver, and maybe a lymphatic circulation that makes you more prone to plastic bronchitis or PLE. Should people be told prior to Fontan surgery that this is a potential risk? Personally, you ask me, I would love to have this MRI of the lymphatic system in every patient before Fontan surgery. That's work that needs to be done. And I think we should have that conversation. And I'm starting to ask to people when they have a Fontan operation, did you have a cardiothorax before? Because I think these people will be at higher risk to have PLE later. Now a question about the Fontan registry from Australia and New Zealand. That's a lot of questions. Can you share with us the importance of Fontan registry and what a unique resource this is? When I started this Fontan registry, I never thought that it would take so much importance. The Fontan registry is important because it's the largest database in the world of people with a single ventricle living with a Fontan circulation, and it's the only population database. So we have all the Fontan patients. So what it means that's truth. So it's not one center. We don't have some patients of one center or some centers. We have everybody. So that's a clear picture of what reality is. And we have the longest and largest follow-up. So the first thing that we did is we clarified the expectations. So we clarified the expectation. We said, hey, the results are much better. So that is a paradigm shift. If the results are better, in the cases where you can do a difficult operations with 2 ventricles, but it may not work, or you can do a Fontan, then if the outcomes of the Fontan are so much better, then you do more Fontan than you do difficult biventricular repairs. And I think that's the very important things that we've brought is that by showing that the results were better than expected, the people were caught up. Now we're showing that, we have a survival of 85%, 30 years after Fontan, so to 30, 40, 35, 40 years of age. Well, they're there. So we're showing that they're going to double. The number we have is going to double within 20, 25 years. So we have probably around 60,000 people around the world, 40% of them likely over 18, and they're here. They work, they study, they do their job. We cannot turn our back to them. So we have to do something. So I think that the medical community has not done a very good job in the last 45 years. There's a lot of things we could have done before to not be in a situation, to know better about how this circulation works, whether ACE inhibitor works, what is the better anticoagulation for these patients. And now the people have been caught up. They're not desperate. If the people were pessimistic, they said, oh, they don't want to think about it. But now, if we prove that the situation is much better, then hey, we know that there are troubles and we have to solve them. So we have to work. I think that we have done is that we've given an impetus to the research in that field. The unique resource is that every time we ask ourselves questions, the question that can be answered to that, but there's some questions that very, very quickly we have answered to. How can the Fontan community best support the registry to continue its amazing work? Well, so it's a fantastic tool. Every meeting in the world, every paper scored the work that is done in Fontan registry in Australia and New Zealand, and that's one of the amazing things is that Australia is quoted for best research in that field every time. And we can be very proud of it. But it's a fragile undertaking. So in less than 1.5 years from now, our funding will be dried out. We got most of our funding from the NHMRC, and there's so much that the NHMRC is giving, so they lose interest after a while. So it was okay for a while, but it's a difficult field, and it's getting difficult to fund registry. So my motto right now is that you should not ask what the Fontan can do for you, you should ask yourself what you can do for your Fontan. It's your registry. I've created it, I've initiated it, but I haven't. It's not my registry. It's the registry of everybody in Australia, and it's the registry of the patient. So if it died out, you're going to have to support it one way or another. And I'm not sure that. Most of my research work is trying to get money to keep this research going, but that may need your help at some stage. And I don't know how, but you have to step in and take it as yours and help it. What are you most excited about in terms of current research that the Fontan registry is undertaking? I think that there's a few things we're going to be able to clarify. I'm a bit excited because I think that we're going to be able to sort out medications. We're going to be able to show whether ACE inhibitor is useful for kidney disease, whether ACE inhibitor is useful, generally speaking, for the people. We're going to be able to help out a lot in defining whether pulmonary vasodilators, drugs that dilate your lung arteries, are useful on the long term. And then there's a lot of different research that are being done. One of the things that is close to my heart is instituting exercise training in this population. And we've tried twice already to get funding. We may get some funding to study that phenomenon, and we will try to get funding until we do it, because we need to do it. It has to be done. We will do it. Exercise seems fundamental for people with a frontal circulation. We have to achieve that. There's the big things. These are the big pictures, and then there's small things. At the end of the day, I do research because I love to answer questions. I love to go into unknown territories and be the first one to have the answers to a problem that nobody has solved before. One of the things that I'm doing now, for example, is I'm trying to find out whether rhythm problems may be very important in patients, and more precisely, if there are a group of patients who die suddenly because of rhythm problems. And we've just finished a study that seemed to show that I have identified a group of patients who may be at risk of coronary problems. So they don't have enough oxygen going into the heart muscles, and they may die suddenly, like people have heart attacks with coronary artery disease. And that's exciting because there may be solution for that. We may need to put defibrillators in some group of patients. And it's not a lot of patients, but it's completely new, and I have been the first one to put the finger on that. So that's exciting. And so we're going to expand it to other people, and we may have the support of industry to examine that. We're going to likely try to have some monitors to record the heart rhythm of Fontan patients for 3 years, and we can. It's a magnificent, tiny machine. It's like James Bond movies. Like you put something on the skin that you don't see, and you can talk to it at a distance from a mobile phone. I think we're going to have enormous data from that, and that may change the way we treat some patients. Maybe not the 60,000, but maybe 500,000, 1,500 patients who will be at risk of dying that we may rescue. And then we're going to do some work on understanding how the Fontan works, and I think that we're going to look at this venous pressure on the Fontan. We're going to change the way we investigate Fontan, and so that's what I'm excited with. What are you most proud of with regards to the achievements of the Fontan registry to date? Research is sometimes a work of ego, and when it's nice to put the words largest, longest, and that's what the Fontan has achieved. I'm very proud on the fact that it is quoted to be the largest or the most effective collaborative work in Australia and New Zealand. And because of the Fontan registry, that's the first work where really all the adult centers taking care of congenital heart disease in the country and the pediatric centers, all of them are working around the same group of patients. And because that work, all the other patients benefit from that. So putting everybody around the same table is an exhausting but a remarkable achievement. I'm very proud of the fact that that gives us international aura, and that gives me the possibility to build up international collaboration, because we have become so important on the block. I can talk to the most important people in the world of Fontan. So finally, we can gather not only all the people in Australia, but the people around the world to work together, and that's what is needed. But what I'm the most proud of in the regards of the achievements of the Fontan registry is you. The fact that we have been able to work and build up a community of patients, people who have been up to the Fontan registry isolated and believing they were alone on earth with the Fontan circulation, and being able to talk to each other and build up a community and chatting together and build up confidence and asking questions and being, a powerful group of people. I think that's amazing, and for me, that puts a model of how the research should be done and how even the clinical care should be done. I think that's the amazing involvement we have of all of you in the Education Day. I think that's what the most unexpected accomplishment that has arisen from the Fontan registry research. Fontan community, here we're getting. How important do you believe the voice of the community is? Essential. Cystic fibrosis has improved to the stage it has just because of the parents' voice. You have to get together and being a powerful group that lobbies for the well-being of your kids and yourself. Absolutely essential. How beneficial have medical professionals found the Fontan Education Day in regards to hearing from the community directly? Personally, myself a lot, and others as well. And, doctors, lots of them are very clever, don't listen to other people a lot. And, so you have a variety of feedback from medical professionals. But usually the people have been touched and have found that an amazing experience. And so we're going to develop the same model internationally. So we have our first international Fontan meeting in February in Arizona, and that will be advertised. On the same model, we're trying to having all the participants participating. I thought the amazing things I thought was at the first meeting in the Education Day, we had, I remember Dominica talking about pregnancy and having all the medical data, and that was very interesting. And then Louise talking about her own experience. And then you get the patient perspective and the medical statistics, and then if you take one in isolation, you get quite a bit of information. But if you put both together, it's amazing how clear becomes the issues. You have Bryn talking about exercise, then you had Brian talking about his life experience, and again you put them together, and the picture is clear. I think that dedication there is amazing. The future. Do you think we are more likely to have a breakthrough in mechanical heart assist device or grafted printed cardiac stem cell tissue for future repair? Well, I've been a guy doing mechanical heart assist device. I've built up the VAD program, so the artificial heart programs in the Children's Hospital. I have been trained in a hospital in Belgium, which was one of the European training center for artificial hearts. I've been the first guy putting for the first time artificial hearts in the UK at the time when I was in training there. You don't ask me that question. Of course, I do believe that artificial hearts will work better than grafted or whatever, xenograft or anything that build up with stem cell. It may work, but somehow I do believe that for companies, you know what it's like. If they can build up something that works, that they can put in a box and send you by mail and get it to you, especially with internet orders, that's going to work better than if you have to have special farms and a lab cultivating your stuff where you have to go and get your own tissue. If you can send it by post, I can tell you it's going to work better for the industry, and you need the industry to have this undertaking. But you never know. What is your thoughts, opinion on Rutherford's Fontan blood pump? I'm very glad that Mark is working in this field. He's been working in this field and he's been the most advanced to have a proposal. And I think it should be encouraged. And I hope it's going to work. It's a good idea. The thing, that's the positive side. The negative side is what you have to know if you look at the field of artificial hearts, is that most of the artificial hearts that are today on the market have been built up by 2 or 3 large companies who have had experience for more than 20 years in artificial hearts. It's very difficult to start up and build up a new device that is working from scratch. So he's facing ahead large difficulties, and it's not progressing. It's not progressing quickly. I hope it's going to work. It has gained some momentum, and interestingly, it has now gained momentum because group of families and patients have lobbied to get enough money to push that project. That would have been on a block if the patients and family would not have intervened in the US rather. And actually, they've made some crowdfunding, and they had good support from Australia too. Thank you for it. Is it something we should? But the thing is not the only one to work on the field, and so I can't speak too much about it. But there may be other developments. It's not the only one to work on the pump for Fontan. Is it something we should be excited about for the future of Fontan patients? There's no doubt in my mind that will be part of the solutions. I've been believing in that for the last 20 years or so, and I'm still believing in that. Looking ahead, what do you think would ideally be a post-Fontan care plan that is consistent across Australia and New Zealand? I think I've alluded to that as a personal level, but it's not shared by everybody in Australia and New Zealand. You need to have some form of imaging of the Fontan circulation in the first year after the Fontan. You need to be seen regularly by cardiologists. You need to have some form of exercise study. You need exercise training program, psychological support incorporated in the care. And I've talked about MRI, Holter, exercise study at the time of the transition and later on in adult life. Did you get additional questions to ask?
I don't know.
I see on the side there's a lot of questions. Do I have to read this?
Yes.
Okay. So how do I scroll through that?
Sorry?
So I scroll, is that at the back? Where did it start? Here?
Yeah.
300 questions?
Not
Where's the
quite.
beginning?
So the beginning is here.
The beginning?
Correct.
Is there anything you can say? Thank you, Morgan. Jimmy, is there anything we can say or do to convince the NDIS or Centrelink that having had a Fontan is a form of disability? I think this initiative is in the hands of Heart Kit, but please liaise with Heart Kits. They're very sensitive to that question. Heart Kits recently, yeah, clear. Jamie, I can answer that. Heart Kits, roundtable in Canberra, yeah, okay. It's getting 6 o'clock, so we'll put in. Can you go from a Fontan back to a biventricular circulation through the ventricle recruitment in Australia? So I can try to answer that in the dark. We in Australia have not gone back to biventricular circulation. I'm aware only of one case, and I think that after a few years of a Fontan circulation, your heart is not ready to go from a Fontan to a biventricular circulation. It's getting too small and too stiff, and it would be very difficult undertaking. Okay. So more questions about support. I was told the point of focus of the group may have changed. Thank you, Roxanne. The concern about pregnancy. What are the risks, the concern for someone who had a Fontan as a child and now an adult who wants kids? You can tell them that it's at the entrance, at the far entrance of the
Outside.
Yeah. So the concern of pregnancy are real. It's difficult to get pregnant. There's clear risk of having a small baby prematurely. And there's more risk of bleeding for the mom. In Australia and New Zealand, we've been able to have successful pregnancy with no early impact on the mom, and some good success with children, but it's not an easy undertaking. And the question that we ask ourselves that is unclear, and we're going to do international collaboration to answer that question, is that does that have an impact on the circulation of the mom once she's got a pregnancy on the long run? And thank you for Libby, Belinda, Rachel, Jess. Okay, is there any research into developmental delays in Fontan kids? Yes, there is. If you have congenital heart disease, you're more at risk of decrease or impaired neurodevelopmental outcome. I would not especially talk about developmental delay, but what you can find out is that you can find, if you look for it very closely with very fine investigation, you won't notice like anything like that, but fine motor skill change and some cognitive skills impairment. So people who do not as well at school. One of the things is that it would be interesting to look at that, and it would be nice if the DHS was funding for investigation of these outcomes at about 3 or 5 years of age, before school age, because you can do something about it. You can provide a bit more support at school, and that would be efficient to put you back into the normal. Why do you have that is unclear. If you have a Fontan circulation, single ventricle or biventricular circulation, it seems that you don't have a difference. So you have as risk to have this than if you have a biventricular circulation. So we don't understand. We want to do a study that look at the things that can cause for that. So the things that can cause that is an abnormal flow into the brain before birth, abnormal maturation of the brain. And yes, the surgery may have an impact on that. Genetic issues may have an impact on that, but it looks like genetic malformation counts for about 25% of the difference observed in neurodevelopmental outcome between patients with a heart disease and people who don't have a heart disease. And surgery and all the events around surgery counts for only 5%. So the other 70% are genetically coded things that we do not understand, brain maturation before, socioeconomic impact as well. If you work more on your brain, maybe you have better brain. So there's research in it. And you do biventricle prior to Fontan. I'm sorry, Mary, I do not understand that question. Annie, okay, what are the arguments for and against fenestration closure? We had a case discussed at our conference today, and we had lots of discussion. And there's still a lot of disagreements. I have completely biased views myself, and I'll take the opportunity to answer that. I think we'll find a difference, but right now we could not prove the difference. The people have said that if you have a fenestration at the time of the Fontan, you tolerate the experience of the Fontan at the time of the surgery better. Some evidence of that, but not consistent. So not everybody agree, but grossly speaking, it seems to be a benefit at the time of the surgery, but people disagree with that. On the long term, some people have said that if you have a fenestration open, you have an increased cardiac output. That's an increased cardiac output generally on anesthetized patients in a cath lab. You don't seem to have an increased exercise capacity. Most of the study done so far are unconclusive. That being said, if anybody who's got, like me, 98, 99% saturation, and I put myself or anybody with that level of normal oxygen saturation to a oxygen saturation of 5% less, even 92% saturation, I'll be struggling a lot. I mean, I just have to run an altitude to know that if I have less oxygen in my blood, I'm not going to be able to run that fast. So for me, it makes sense that if you have more oxygen in your blood, your exercise capacity will be better. And my little experience of people who are super fit Fontan is that usually they don't have a fenestration output. But watch this space, we don't know, and we'll see. I think we'll know within the next 2-3 years. Thank you, Blake. I've discussed about the best age for Fontan. Shouldn't wait. Whether it's 3, 4, 5, or 2 or 3, I don't know, but you shouldn't wait too long. I've mentioned that at the beginning. I don't know about, I haven't heard before about tremor with a Fontan. I would refer that question to a neurologist, and hopefully we have a neurologist participating to that at some stage to participate in a Q&A. The focus heart groups. Okay, is that all? I think I have a question of Nicole, I think.
Excellent. Well, thank you for your time. Well, hit
Thank you
end
very
on
much.
the live.
Finish.
Finish.